My topic is on Fabry disease, a very rare disease, as you can all know, and the cardiac involvement. As you know, Fabry disease is an X-linked inherited disorder with lysosomal storage disease due to accumulation of what we call the GL3 particle in all kind of organ and tissue, with multiple systemic involvement and progression with life-threatening process affecting both males and females. This is an overview of my topic today, inshallah. As you can see that this is transmitted through the X chromosome, so that if we have a male affected person, the general rule is that there is no male to male transfer. So for example, if we have a male carrying the disease, the genes, married to a normal female, and then we have no male involvement, but there is always 50% chance of his offsprings to develop or carry the genes. However, if female carries the gene and the offspring would be like 25% of female would have the gene, and 25% of the males will have the gene and affected disorder. The key issue is that no male to male transfer in this regard. It is estimated that 1 every 40,000 of male birth and 1 every 20,000 of female birth that might be affected with this rare disease. However, in the recent new screening study in the newborn, this is unfortunate, of course, it's not a regular routine screening disease. However, if we apply the screening to a newborn, in one of study, it was discovered in about 3,100 new birth. It is affected all the ethnic background, and of course, males usually would present with the classic form of Fabry disease, and usually at early stage of their life. Female, however, can be as severely affected as males as well in all spectrum of the disease, as we will see. This is the product that's called globotriaosyl ceramide or sphingolipids. The enzymes alpha-galactosidase A that actually break this product and into a subgroup. However, in the absence of these enzymes, alpha-galactosidase enzymes in the body, or lack of its activity or decrease of its activity, then there is accumulation of this GL3 product, and then it will be engorging and deposited in the lysosomes. This is kind of in a sketch of relative size of a lysosome, normal lysosome, versus a lysosome that is full with a GL3 product. The GL3 products, of course, with its higher level throughout the circulation and the body tissues, then it tends to accumulate in different kind tissues. This is an example of the accumulation of the GL3 in the endothelium and in the myocyte itself. It can be in the endothelium, it can be in the myocyte, in the kidney as well. We will see a few pictures about it, and the central nervous system and peripheral nervous systems as well. In children, there is little difference in presentation than the adults. Most of the time is the GI symptoms, even like pain, what we call pain crisis in newborn, or even like small little children. Angiokeratosis is one feature. We will see a picture of it. The corneal involvement, and of course cardiorenal involvement is quite common at this stage. However, in children, usually left ventricular hypertrophy, which is the most common presentation of Fabry disease in adult and adolescent. This is kind of relatively in a very small percentage in the children. However, this is more prevalent in adult population. This is an example of corneal involvement. It's called the cornea verticillata. It does not affect usually the vision in general in these patients. Angiokeratosis, it can involve the skin, usually between the umbilicus and the thigh. However, it can also involve the mucous membranes. So as we mentioned, in pediatric, The main manifestation of cardiac involvement is basically arrhythmias and ventricular valvular heart disease, because left ventricular hypertrophy is relatively considered a late presentation of the disease. As we mentioned, it does not affect only the males, but also female would be presenting with the disease as severely as the males. This is an example of a male person, young, with involvement and deposition of the GL3 products in the endothelium of the kidney, and also in the podocytes of the glomerulus and in the mesangium as well. That actually in progressive stages can progress into full focal segmental glomerulosclerosis. This is another case in two girls as well. Young girls that actually the biopsy showed of the kidney showed like the position of the GL3 products in the media of an artery, and also that can of the glomerulus, that which can also may progress to a full-blown focal segmental glomerulosclerosis. Generally, quickly, the end problem with the patients with renal involvement, it can progress from microalbuminuria to proteinuria into full-blown hypertensive and end-stage renal disease requiring renal transplants. In adults, there is more manifestation and cardiac involvement than the children, although the general I don't know why it's not reflecting the cursor here, but anyway. So in general, there is more involvement of the cardiac involvement in Fabry disease than the case, and we will go in more details about these manifestations. However, the rest of them, the same: kidney, CNS, peripheral neuropathy, etc., pretty much the same as in children. So Johannes Fabry and William Anderson, both in 1898, almost simultaneous at the same time, they described this kind of disease, and they are both dermatologists concerned with, angiokeratosis in these patients that actually describe the disease early in that age. So in our focus on cardiac involvement, we will discuss the ECG, echocardiogram findings, and the cardiac MRI. Generally, cardiac involvement, about 14% of females and 20% of males will present with some sort of cardiac involvement in Fabry disease, mostly left ventricular hypertrophy and cardiac arrhythmias. The event rate in both genders pretty much the same. However, there is tendency that in males would precede the development of cardiac involvement than the female. Average 42 years of age versus 48 years of age in female. As we can see here, cardiac arrhythmias, about 11% in males and 7% in female. Congestive heart failure, about 4% in males, 3% in female, and left ventricular hypertrophy, about 22% in male and 18% in female. So this is a good start point for us to screen and pay attention to this rare disease that is left ventricular hypertrophy, which we are going to dwell on it in a little bit more details. So that in arrhythmias is quite common, so that at age of 45, males would, 50% of them would have presented with some sort of arrhythmias, versus there is like, a little delay in females in the 5th or 6th decade of their life. What are the ECG's changes that might draw our attention that there might be underlying Fabry disease? Those changes can be classified to kind of, early changes and late changes. As you're all familiar with that, the hallmark of the Fabry disease and cardiac involvement is left ventricular hypertrophy. But there are some more subtle signs that we can dwell on. That is, the P wave and the PR interval and the PQ interval. As you can see here, despite this remarkable left ventricular hypertrophy here in V4, 5, and 6, I don't know if there's is this working? Why is not, okay, all right. Oh, thank you very much. So as you can see, despite the remarkable LV hypertrophy, yet if we look and screen quickly here, you can see how small the P wave is and how short the PR interval. So that in recent study, that we found that comparing patients with Fabry, cohort of Fabry patients, and normal cohort, they noticed that there is remarkable P wave shortening, remarkable PQ and QRS duration shortening, compared with what we call repolarization abnormalities, that is QTC interval. Further than that they noticed that the main confounding factor, that is the P wave duration, that actually responsible for this PR or PQ interval shortening. Compared, for example, in patients with Fabry's, the maximum is like about 90 milliseconds of the P wave, compared with the normal is about 120 milliseconds. Quite clear difference. So going further, that in late stage that we can, further than that is the QT interval, or what we call repolarization abnormalities, that is manifested as in a very delicate way of assessing that, but by what we call QTC dispersion and the T peak to T end dispersion. If we look at the peak of T wave and the end of T wave, if we measure this distance and take the difference between the maximum distance to the minimum distance, we can see that in patients with Fabry disease, they have remarkable dispersion compared with the normal cohort. The same thing is the QT and QTC interval dispersion. We can see a remarkable difference between the patient with Fabry versus the cohort, and also TEP to TE dispersion. These are all indicative of some advanced repolarization abnormalities in these patients. However, this takes special device in order to to identify these subtle changes. However, we can rely heavily on LVH, short PR or PQ interval, and short P wave duration. I think this is your key for the screening those patients. So abnormality of the repolarization can actually, and dispersion of QTC and TBTN dispersion can also lead to lethal arrhythmias. That is quite common in patients with cardiac involvement in Fabry disease. Later changes, however, with incremental deposition of all these GL3 in the myocyte and in the cardium, etc., this actually lead to fibrotic changes, fibrosis. We will see it also. It can be identified on echo and also on CMR, that can transmit from either subendocardially or transmurally, when involving the whole myocardium, actually transmurally. That actually, this is the correlated. There is correlation between this finding and lethal cardiac arrhythmias. How about echocardiogram? We will dwell on the. So we cannot combine both. Anyway, so we'll dwell a little bit on left ventricular hypertrophy. This is a case of Fabry disease that actually referred to our center back in 2010. And the patient actually 26 years old, and identified by other center with end-stage renal disease. Upon screening, actually, this patient, because on the echocardiogram, I'm sorry, this is not a right depiction of the study, because this is kind of little stretched out. So, but you can see and you can identify there is significant left ventricular hypertrophy in this patient. And patient actually presented to our center, being King Fahd Specialist Hospital in Dammam, is a referral center for multi-organ transplant, was referred for kidney transplantation. So this patient actually presented with this kind of echocardiogram, severe left ventricular hypertrophy, mildly LV systolic dysfunction in the fourth chamber, as we can see how remarkable the hypertrophy. And you can see like there is a little tiny lucency. This is not working. No? Laser? No laser? All right, that's fine. So I can use here the pointer. And as you can see, there is little translucency just beneath the endocardium. We will talk shortly about it, what we call the binary sign, or the binary appearance of the septum. And also in the apical 2. How can I get it out? How can I take it out? Yeah. So here in two chambers, again, we see how remarkable the left ventricular hypertrophy, especially the most actual deposition is in papillary muscles. As we mentioned, one key indication for the Fabry, actually very subtle also finding, is that despite this remarkable LV dilatation and LV hypertrophy, you can see that there is only tiny mitral regurgitation. So this is one of the key features in Fabry disease, that patients, despite significant LVH and despite like dilatation and mildly decreased LV systolic function, but you can see that the mitral regurgitation is very little. Same thing, AI and TR, etc. All actually they have only mild insufficiency. So, and of course, we should not forget the three-dimensional echocardiogram. This is a reproducible tool and very nice and easy, can be done, especially like, for follow-up of these patients. So LVH in Fabry disease could be the first sign of presentation, and echo is a good tool for follow-up and identifying and diagnosing those patients. However, the key feature is that there is no significant systolic dysfunction, and there is no restrictive diastolic signs. It's only, most of the time, it is only abnormal relaxation. And that's why the genetic counseling and the genetic testing is quite key feature in these patients. Left ventricular hypertrophy not only is concentric in the majority of the patient, but also could be asymmetric septal hypertrophy, just like we see it in HOCM. And also it could be like even in the apical variant, Yamaguchi type left ventricular apical hypertrophy as well. And we can identify that by the left ventriculogram and also by the prominent ECG changes of these marked T-wave depression and T-wave abnormalities. So the prevalence of this LVH is quite common at late stage of the disease and older patients, as you can see in the fourth and fifth decades of patients. The other feature is that, we can have to specify it is the left ventricular morphometry. As you all know, there is the normal and there is the concentric remodeling and concentric ventricular hypertrophy and asymmetric. In one recent study, actually, it found that the majority of patients with Fabry, they would have the concentric hypertrophy type of presentation. Less to that is the concentric remodeling and eccentric hypertrophy and ASH. I think we're familiar how we do that, in general. So binary sign, just quickly, it is just little translucency just beneath the endocardial border, and its significance kind of, still controversial. Some would say it is kind of an almost pathognomonic, but actually in some recent studies said it is not, because it lacks the sensitivity and the specificity for Fabry disease. 1 minute, okay. So just to show that, there is an increased space in the subendocardial space, that along with the involvement of the subendocardial myocardium and those patients who presented with this kind of interesting sign, the binary sign. This is when compared with those with left ventricular hypertrophy without the binary sign, we can see barely no involvement of the subendocardial myocytes. There are a bunch of differential diagnoses for left ventricular hypertrophy on echocardiogram. Just quickly on the diastolic parameters, it was found that early diastolic parameters is a good sign to detect actually early cardiac involvement before left ventricular hypertrophy changes, as we know that LVH is kind of relatively late features. TI index is very promising, especially when it is associated with left ventricular posterolateral fibrosis and thinning of the posterolateral segment. It was shown that it has a progressive feature of the Fabry disease, and also it has also prognostic feature for Fabry disease that actually might end with progressive heart failure class 3 and even death. This is just quickly how we identify the posterolateral. It is invariably involves the posterolateral wall of the left ventricle that we can identify more in the CMR, as we will see. Again, reminder that only minor mitral regurgitation or aortic insufficiency in these patients, and despite the remarkable left ventricular hypertrophy and dilatation of the ventricle. MR could be very helpful in identifying early stages of subendocardial involvement and also progressed stages when it is involved the transmural left ventricle in these patients. These actually, once with development transmural changes, usually they tend to progress to full-blown congestive heart failure, and of course the management in this situation, just like heart failure in the guidelines. As we say, Fabry disease is life-threatening, and it can shorten the life expectancy by 15 to 20 years, especially in males versus female. And this is some differential diagnosis. And the only one point that I would like to see here, to show here, is that the delay between the onset of symptoms and the diagnosis of this rare disease. Average about 15 to 20 years delay in diagnosing and confirming diagnosis between the appearance of the symptoms and the diagnosis of the disease. So how we screen and manage these patients? We measure what we call alpha galactosidase enzymes activity in leukocytes preferably. And now it is very simple. It's just like a blood sugar test, a finger prick, and you apply it on the kit and send it for the core lab. How we suspect that, in males, we can do it easily. If it is positive, then we can refer for treatment. If in female, if it is positive, we need additional confirmatory testing with genetic, actually DNA testing, and once it's confirmed, they can be referred for treatment. The key issue is that once we discover one index case, there is always potential 5 to 6 cases in the family that can be discovered and implemented treatment in these patients. Just to say, this is our protocol, is that, as we mentioned, in that we started implementing it back in mid of this year. And we screened about 25 patients of the patients. So just in summary, Fabry disease is quite a life-threatening LSD storage disease with a progressive nature. Chronic kidney disease and left ventricular hypertrophy are the key feature that you can start your screening from on ECG, echocardiogram, and progressive decline of renal function. Those are your top patients, high-risk patients that you can refer them for the test. And thank you very much.